This is part C of the Practical Transfusion Medicine series for internal medicine residents rotating through the hematology ward and consult rotations at the University of Alberta Hospital in Edmonton, Alberta. This is Dr. Wong from the Division of Hematopathology. So in part C, we're going to talk about a general approach to transfusion adverse events and reactions, as well as informed consent for transfusion. So let's talk about a case. So your page while on call for medicine, the patient is a 68-year-old woman who developed a fever of 39.1 Celsius about 15 minutes into a red cell transfusion. Past medical history is pertinent for myelodysplastic syndrome treated with supported transfusions, and she is really here for COPD exacerbation. Labs-wise, her pre-transfusion hemoglobin was 78 grams per liter. So fever occurring during or post-transfusion may have nothing to do with the transfusion, so unrelated to the transfusion. And in my clinical experience, I would say about half of the cases are unrelated to the transfusion, but if they are related to the transfusion, it is most often a febrile non-hemolytic transfusion reaction. Other causes to consider if there's a fever occurring temporally corresponding to the transfusion is bacterial sepsis and acute hemolytic transfusion reaction. So in general, what should be done if you're suspecting a transfusion adverse event? Well, number one is stop the transfusion. Number two, maintain the IV line open with normal saline. And as a part of the normal transfusion protocol in the Edmonton zone, full set of vital signs including temperature, heart rate, blood pressure, respiratory rate, and oxygen saturation should have been done right before the transfusion and 15 minutes into the transfusion, and then at the end of the transfusion if everything went well. So by the time if you're called about a possible transfusion adverse event, there should be at least 2 full sets of vital signs for you to compare. By the time you're called, a clerical check should have been done at the bedside. The nurse responsible for the patient would have checked to make sure the product tag matches the patient's ID band and BBIN number to make sure the correct product was hung for the correct patient. This is all part of Alberta Health Services Transfusion Safety Protocol. And then next what should happen is a transfusion reaction investigation, meaning that the vital signs are documented and any symptoms of the adverse event are documented on the back of the product tag, and then the remaining product, if any left, including all tubing, are returned to the blood bank so that the blood bank can do our own clerical check. And then in addition, a specimen, a peripheral blood specimen in an EDTA tube, is also submitted to the blood bank for the transfusion reaction investigation. And as part of that, the blood bank, once we received all the product returning back to us, the information on the paper tag, as well as the EDTA purple top tube to do investigations, the blood bank tech will inform the transfusion medicine physician or resident on call regarding the possible transfusion adverse event to do additional follow-up. So this is the transfusion reaction investigation tube. Just like for type and screen or cross-match, it is a peripheral blood specimen put into EDTA. All signs and symptoms that could be related to a transfusion adverse event should be documented. So if you're informed of a possible fever, remember to ask about other associated signs and symptoms, such as chest pain, respiratory symptoms, cyanosis, any skin changes, change in urine color, etc. So back to the case. So pre-transfusion, you note that the temperature was already mildly elevated at 37.9. Post-transfusion, it was 39.1, so there's a difference of 1.2 degrees Celsius. Heart rate before the transfusion was 78. Post-transfusion, she was a little tachycardic at 120, but still in a sinus rhythm. Blood pressure, 140 over 70. Post-transfusion, the systolic pressure went down a little bit to 100 over 60. Oxygen saturation remained unchanged, which is important to note. So in addition to the febrile response of at least 1 degree Celsius related to the transfusion of the red cells, the patient also described having significant rigors and chills, which kind of fits with the scenario here. So other questions to ask to sort out whether this could be a febrile non-hemolytic transfusion reaction is, well, was the patient febrile before the product was ever transfused? So you would go review the vital signs charts to see whether the patient has already had a low-grade fever or significant febrile episodes before the product was even started to run. On the hematology ward, many patients receive Tylenol as a pre-medication. So if this patient did receive Tylenol pre-med, they may not actually have adequate temperature rise of at least degrees Celsius for you to suspect a febrile non-hemolytic transfusion reaction, but they may still have significant rigors and chills, so that is important to remember. And what is the underlying diagnosis? So if the patient came in with COPD, as this patient did, maybe the transfusion of the red cells was just temporally correlated to the rise in degree in temperature, and the patient is really just developing a pneumonia or has recently aspirated, so this may have nothing to do with the product transfusion itself. So what is your role in a transfusion reaction investigation? Well, you are the blood bank's eyes and ears, because you're the one looking after the patient. You will be the one called to see them when you're on call. So the transfusion medicine physician on call, once notified by the blood bank about a possible transfusion reaction or adverse event, will call the ward to speak to the nurse to obtain additional clinical information, and as well as yourself on call to seek additional information about the patient, what you found on the physical exam, what interventions were given to the patient, and if they have responded and how they're currently doing. So basically, our collective role is to provide guidance for additional testing and to advise on additional product support if clinically required. So what other tests can be ordered? So if there is a significant febrile reaction, especially if the temperature goes above 39 degrees Celsius and there's a severe febrile reaction, and for example, bacterial sepsis is a distinct possibility, so we can request blood cultures from the patient, and then we can also culture the remaining product left in the bag and or the tubing. So this is a reminder to please do not throw the remaining product or tubing into the garbage, but to please return everything to the blood bank because we will use it in some way. In case of an acute hemolytic transfusion reaction, we can ask for a hemolytic workup, for example, repeat CBC, reticulocyte count, LD, total bilirubin, and haptoglobin to assist in our workup. If there are any respiratory symptoms and or symptoms of hypoxia or bronchospasm, etc., then the most important vital signs to obtain are the pre and post transfusion respiratory rates and oxygen saturation. I must say, in my clinical experience, the oxygen saturation is the most commonly forgotten vital sign, even though part of the paper tag that is returned to us denotes that the patient was having respiratory symptoms. So that's when we also call the ward and speak to the nurse and yourself to inquire how the patient is doing now, what you found on the pulmonary exam, were there any crackles, wheezes, is the JVP elevated, if they're in ICU, what is the CVP currently, is there any fluid overload, for example, the fluid ins and outs to calculate if the patient could be fluid overloaded, a chest x-ray to compare to a pre-transfusion specimen would be helpful if there are respiratory symptoms, and even an arterial blood gas may be very helpful. And if the patient received Ventolin, Atrovent, or Lasix, for example, as part of the having respiratory symptoms that could be related to our transfusion, we also call to inquire if they responded to that treatment. So, managing fever during or post-transfusion, I guess that makes sense that you would also give an antipyretic to reduce the symptoms. As I understand nowadays, as part of the ward protocols, Demerol is no longer available on the ward, but morphine still is if the patient is having such bad rigors that your O2 saturation monitor may not be reading properly, and so the patient may appear hypoxemic when in fact they're not. So some medication other than Demerol can be given to the patient to settle down the rigors, and then the O2 sat repeated to ensure that you are really dealing with respiratory symptoms and hypoxia that could be related to a transfusion, because then that puts you into a whole different differential diagnosis. IV antibiotics may be adjusted and or added or changed depending on the clinical scenario. if you suspect an acute hemolytic transfusion reaction, it is important to maintain IV fluids and monitor for urine output, because intravascular hemolysis releasing free hemoglobin is directly toxic to the kidneys. And of course, you should monitor for end organ complications such as DIC as well as multi-organ failure, but the treatment for this is actually supportive. In general, should the transfusion be restarted? In general, we recommend that the original transfusion or product should never be restarted. Any remaining product and tubing should be returned to the blood bank. If more product is clinically required, then the transfusion medicine doc on call would discuss with you whether it is safe to issue a new product, and if we do decide that it is necessary, then the blood bank will be more than happy to issue a new product, for example, red cells. Case number 2. 30-year-old woman with postpartum hemorrhage. She is quite short of breath and quite dizzy. Her hemoglobin is now down to 68 grams per liter. You recommend red cell transfusion, but she is worried about getting AIDS or hepatitis C. So what do you tell her and what do you discuss with her? So this is a lead-in to discussion about informed consent, as well as the risks of transfusion-transmitted infections and other adverse events. These are just some general numbers to keep in mind for some transfusion-associated adverse events. So a febrile non-hemolytic transfusion reaction happens for both platelets and red cells, but is more common in platelets because platelets are stored at room temperature, whereas red cells are stored in the refrigerator. Allergic reactions, mild to severe, occur in 1 in 100 to up to 1 in 40,000 per component unit, and runs the gamut of just having a rash or urticaria and no other symptoms to a generalized, almost anaphylactic reaction. TACO stands for transfusion-associated circulatory overload, and that is estimated to occur in about 1 in 700 transfusion episodes. TRALI stands for transfusion-related acute lung injury, and we will go into this a little bit more in the following slides. It's estimated to occur in about 1 in 10,000 transfusions. Symptomatic bacterial sepsis, it's not very common, but can occur with platelets or red cells. For platelets, again, because of the room temperature storage conditions, occurs in about 1 in 10,000, whereas for red cells, because of the refrigerated conditions, occurs only in about 1 in 250,000. That being said, if your patient did have symptomatic bacterial sepsis with platelets, it is most commonly due to commensal skin flora, and for example, your Staph aureus or coagulase negative staph species, and clinically they would not be as severe as it is related to red cells, in which the culprit organisms are bad things like gram-negative organisms such as Serratias and your Yersinia organisms. ABO incompatible transfusion, despite how strict we are about accepting specimens for testing, unfortunately still occurs in about 1 in 40,000 red cell episode, and they can be fatal. Risks of adverse events for transfusion transmitted diseases. So when you go donate blood, whether whole blood or apheresis platelets or plasma, your blood will be tested for hepatitis B and C, HIV 1 and 2, HTLV 1 and 2, West Nile virus seasonal testing only, syphilis testing on all specimens. Platelets that are collected will undergo bacterial contamination testing in mini pools of 6, and depending on your questionnaire that you fill in before you go donate, Chagas disease testing may or may not be done. So with all this testing, the residual risks of transfusion adverse transmitted infections are actually quite low in terms of the 1 per millions. So for example, hepatitis B, and that is chronic hepatitis B, is estimated in 1 per 1.7 million. HIV, for example, is estimated to have residual risk of only 1 per 8 million.